Guys, when a patient comes to you and they complain of a what? Of a dull and poorly localized pain associated with their tooth. Okay, that's a C nerve fiber that's being activated. Okay, a C nerve fiber usually gets activated near the end of the irreversible pulpitis stage, which means that this tooth has gone through the irreversible pulpitis and is near the end of the irreversible pulpitis and is going towards necrosis, pulpal necrosis. Okay? See? In most cases, it occurs later as a secondary pain. C fibers have a high threshold and can be activated by intense heating or cooling of the tooth. All right? So patient complains of heat sensitivity. That means that the C fiber has already been activated, which means you're near the end of the irreversible pulpitis stage. This tooth is now going towards necrosis. And then you say, I was at an argument with a general dentist, and she was saying that in cases like this, she just does occlusal adjustment and the patient doesn't need a root canal. See, when you don't know the science, and you make stuff up, it's just really embarrassing. Know your science. So the reason you do occlusal adjustment, you take the tooth out of occlusion pretty much, and then patient gets relief. Do you know why that is? That's because this patient has already, as I said, gone through irreversible pulpitis. Is towards the pulp is going towards necrosis. There's also periapical changes. Inflammation has gone from the pulpal to periapical area. So there's inflammation of the periapical region. So this tooth is super occluded. So when you take it out of occlusion, you do occlusal adjustment. Of course, this patient the tooth is gonna feel better because by then the pulp has necrosed too. So that's why your patients feel better, because now you got a necrotic pulp. But that doesn't mean the occlusal adjustment worked. So patient leaves your office with an occlusal adjustment, and you think that your treatment worked. And later on, when the tooth blows up on this patient, it's very likely that they probably won't come to you. They go somewhere else for emergency treatment because chances are that they don't trust you anymore. And then you think that your treatment worked, your occlusal adjustment worked. So this is called anecdotal science or experiment, science, or no, not science, just anecdotal, and based on your personal experience. It's not rooted in science. So if you don't know your science, you're going to be in trouble and your patients will be in trouble. Today's episode on reading from Pathways of the Pulp. If you do endo, or if you're a dentist, you need to know this book pretty much by heart. So I get a lot of messages from my followers. They're dentists. They send me a couple of x-rays and say, what do I do with this? Does this tooth need a root canal? They want me to look at a couple of x-rays and then tell them if the tooth needs a root canal. Doc, what is happening? Do your examination. Or if you're sending me x-rays, okay, x-rays are fine, but send me the rest. You need to tell me what's going on. Give me the medical history. Give me the results of the test that you've done. You need to have done examination and testing. Page 7 of Pathways. Extraoral examination. Intraoral examination. If there are sinus tracts, swellings needs to be noted. Sinus tracts needs to be traced. Palpation test. Percussion test. Tenderness noted upon percussion or percussing a tooth indicates some degree of inflammation in the periodontal ligament. Percussion test by itself doesn't mean a tooth needs a root canal. It's just a test that you do. Inflammation in the periodontal ligament may be caused by occlusion, trauma, sinusitis, periodontal disease, or extension of pulpal disease into the periodontal ligament. Percussion is not a test of pulp vitality. Thermal tests combined with electric pulp testing that evaluate pulpal nerve function are required to establish pulp vitality. Okay. Mobility. Test for the mobility of the tooth. Periodontal examination. What do I always tell you? You have to do periodontal examination of the tooth. What does that mean? You need to probe the tooth. Probe it. Then you do thermal pulp tests, which is usually cold test. Then the cold test will tell you the status of the pulp. I used to do heat test. I don't do it anymore. Electric pulp test, I used to do it. I don't do it anymore. But these are the things that you need to know. You need to know all of this stuff. Then you look at the multiple angulation radiographs, radiographic examination. And I talk about that, multiple angulation PAs. And then you need to, of course, be able to read x-rays and interpret x-rays. Radiographic interpretation. All right? So don't just send me a couple of x-rays and tell me, hey, doc, what do you think? Does this tooth need a root canal? Read this book. These notes are mine, my handwriting. I took these notes when I was reading Pathways 20-some years ago. Look at that. MTA. What's in MTA? Tricalcium silicate, and tricalcium oxide, and all that stuff. Because of high pH, hard tissue formation occurs after use as a retrograde filling, not adversely affected by blood contamination. MTA in contact with periapical tissue forms a fibrous connective tissue and cementum, causing only low level of inflammation. Oh, my notes. Look at that. Check this out. Notes from 25 years ago. RC prep sequence. Straight line access. If vital pulp and bleeding, filled chamber brimful with a viscous chelator like RC prep. When pulp is necrotic, irrigate and fill chamber with 5.25% warm sodium hypochlorite. Use smaller stainless steel files. Pre-curve to full length. Stainless steel O2 tapered number 10 and 15 hand files are used to scout coronal 2/3. 25 years ago, my notes. After scouting coronal 2/3, canal flushed with sodium hypochlorite, and pre-enlarged using hand or rotary files, with coronal 2/3 optimally prepared and filled with irrigant. Apical 1/3 is scouted and information gathered. You always scout, remember? I always tell you that. Working length is confirmed using X-ray apex locator or apex locator. If you don't have apex locator, you go with X-ray, or sometimes you do both. With root canal negotiated anatomy fully appreciated, a decision can be made whether to finish apical 1/3 with hand files or rotary. Aqueous 17% EDTA flooded into well-shaped prep for 1 minute has been shown to remove and eliminate smear layer. I used to do that. I don't do it anymore because back then we didn't have sonic and ultrasonic activation, but now we do, so I skipped this part. In 1847, Hill developed the first GP-RC root canal filling material called Hill's Stopping. To remove smear layer, wash canal with a chelating agent such as EDTA, 17% EDTA or 10% citric acid, and then thoroughly rinse canal with 3 to 5% sodium hypochlorite to remove moisture from canal. Either 95% ethylene alcohol or 99% isopropyl alcohol left in canal for 2 to 3 minutes. See, these are the fundamentals that I always talk about. I say follow the fundamentals, rubber dam, all of that. These are all the fundamentals. You can see that in 25 years, these fundamentals have not changed. We've added, modified the root canal procedure, okay, but the fundamentals stayed the same. Today's episode of Reading from the Bible, and I've covered this topic many times. Question is often asked in cases of a patient walking in as an emergency. They have a hot tooth, irreversible pulpitis. You diagnose the tooth as irreversible pulpitis, but you don't have time. What do you do in these situations, in these cases? And I always say, do a pulpectomy. Or if you don't have time to do a pulpectomy, don't put a file in the canal unless you commit yourself to do a pulpectomy. Okay, you can do a pulpotomy, but that could relieve some of the patient's symptoms, but not all. But the best ideal thing to do would be to do a complete pulpectomy, and here's why. And again, I've covered this case many times. I've read this book maybe 10 times from cover to cover. So I know what's going on, and that when I give you guys my recommendation, my advice is based on science. It's not based on my anecdotal experience. So here we go. Irreversible pulpitis. Emergency management for painful irreversible pulpitis involves initiating root canal treatment to alleviate the pain, okay? Irreversible pulpitis can be predictably managed by complete removal of the pulp and total and cleaning shaping of the root canal system. In multi-rooted teeth, a pulpotomy, that is the removal of the coronal pulp, or partial pulpectomy, that is the removal of the pulp from the widest canal, have been advocated for emergency treatment of irreversible pulpitis. However, because it is impossible to detect clinically the apical extent of the inflamed pulp and therefore provide predictable pain relief, it is important to perform a pulpectomy at the emergency visit. Good morning. A file should not be introduced into any canal unless a pulpectomy is anticipated. Often inflamed vital pulp tissue that is lacerated with endodontic files will result in increased discomfort. So patient comes into your office with a lot of pain. You don't do a full pulpectomy. You just put a file in the canals. Patient leaves with more. So don't put a file in a canal, into any canal, unless a pulpectomy. You commit yourself to a full pulpectomy. Okay? So often inflamed vital pulp tissue that is lacerated with endodontic files will result in increased discomfort because the pulp has become inflamed, shredded, and traumatized. Pain symptoms can persist or worsen if inflamed pulp remains in the root canals because the inflammatory process will extend into the periapical tissues. Okay? So don't put a file into a canal unless you do a full pulpectomy. Now check this out. Post-operative pain and the long-term prognosis after single visit endodontics is similar to root canal treatment completed in multiple visits. So, to those who say, patient comes in and they're in a lot of pain, it's recommended that we do it in multiple visits, do the root canal multiple visits because of the fact that the patient comes in with pain? No, that's not the case. So, no contraindication to single visit endodontic treatment. Post-operative pain and the long-term prognosis after single visit endodontic is similar to multiple visits. Because temporary restorations eventually leak, obturation in one visit eliminates the possibility of inter-appointment bacterial contamination of the root canal system. Okay? So if you run out of time, if you don't have time, yes. However, time constraints at the emergency visit often make the single visit treatment option difficult. So if you don't have time, then you can do it in 2 visits. But ideally, you want to do obturate in 1 appointment. If I told you that this book alone probably has saved more lives than the Torah, the Bible, and the Quran combined. All right, let's read. Okay, so today I want to talk to you about the periapical disease. All right, this is how we learned it. I know the nomenclature has changed, but this is what I'm comfortable with. I still use this nomenclature, all right? So, periapical disease. We have acute apical periodontitis, acute periodicular abscess or acute apical abscess. We have chronic apical periodontitis, we have phoenix abscess, and we have periapical osteosclerosis. All right. So acute apical periodontitis, just to simplify, is when you percuss a tooth and it's tender to percussion. That's what this means. This is the periapical status of the tooth, not the pulpal status of the tooth. It could be related to the pulpal status of the tooth, but sometimes it's not. Sometimes a healthy pulp tissue, a tooth with a healthy pulp tissue can exhibit acute apical periodontitis. Why? Well, acute apical periodontitis is painful inflammation around the apex of the tooth. This condition can be the result of an extension of pulpal inflammation. So it could be the result of pulpal inflammation, extension of it into the periapical tissue. It could be mechanical or chemical trauma by endodontic instruments or materials, or occlusal trauma caused by hyperocclusion or bruxism. Because acute apical periodontitis may occur around vital and non-vital teeth, conducting a thermal pulp test is the only way to confirm the need for endodontic treatment. As always, the need for endodontic treatment must be determined by pulpal status alone. Just because a tooth is tender to percussion doesn't mean it'll need a root canal. That's what it means. In today's episode of Reading from Pathways of the Pulp, let's talk about acute periodicular abscess or acute apical abscess, AAA. All right, so what is it? An acute periodicular or acute apical abscess consists of a painful periodontal exudate or abscess around the apex. This abscess is the result of the exacerbation of acute apical periodontitis from an infected necrotic pulp. Although this disease can be very serious, the periodontal ligament may appear within normal limits, or it may be only slightly thickened. This is because the rapid progress acute in the temporal sense of the infection has spread beyond the confines of the cortical plate before the mineralization can be detected radiographically. Thus, the periapical radiograph may only reveal a relatively normal or a slightly thickened lamina dura. So, a patient, basically what it says is that a patient walks into your office, their face is all swollen up. You take some PAs, you don't see a periapical radiolucency associated with any other suspected teeth. But the patient's face is all swollen up. No periapical radiolucency, but the patient's face swollen up. That is acute periodicular abscess or acute apical abscess. The abscess has developed so fast that there hasn't been enough destruction of the periapical region of the tooth to give you that periapical radiolucency. The only way really to figure out which tooth is the problem here, which tooth is the source of the problem, is pulp vitality testing. Okay, so you pulp test the teeth in the area. The tooth that doesn't respond to your vitality test is the necrotic tooth that is the source of this acute apical abscess or acute periodicular abscess. The signs and symptoms of acute periodicular abscess include rapid onset of slight to severe swelling, moderate to severe pain, pain from percussion and palpation, and the possibility of a slight increase in tooth mobility. Now, really, the only difference between acute periodicular abscess or acute apical abscess and a phoenix abscess is that with the phoenix abscess, you do have a periapical radiolucency on your PA. You do see a periapical radiolucency on your PA. In Acute apical abscess, acute periapical abscess, you don't. That's the only difference between these two. Phoenix abscess, you see a periapical relucency on your PA. Acute periapicular or acute apical abscess, you do not. In today's episode of Reading from the Holy Book of Endodontics, I would like to cover the periapical osteosclerosis. What is that? Periapical osteosclerosis is excessive bone mineralization around the apex of an asymptomatic vital tooth. This radiolucency may be caused by low-grade pulp irritation. Because this condition is asymptomatic and benign, it does not require endodontic therapy. And this is a picture of it. As you can see, this area right here. Now, you read this, right? I read this for you. Tell me what's going on. What's wrong with this paragraph? In today's episode of Reading from the Holy Book of Endodontics, let's talk about tooth isolation, principles and rationale. The use of the rubber dam is mandatory. The first sentence, the use of the rubber dam is mandatory. It doesn't say the use of the rubber dam is optional. It says the use of the rubber dam is mandatory in root canal treatment. Developed in the 19th century by S.C. Barnum. The rubber dam has evolved from a system that was designed to isolate teeth for placement of gold foils to one of sophistication for the ultimate protection of both patient and clinician. The advantages and absolute necessity of the rubber dam must always take precedence over convenience and expediency. And then he also mentions a rationale often cited by clinicians who condemn its use. So some clinicians, they don't use it because they say it's not convenient and it slows me down. So the book says it's absolutely necessary, it's mandatory, get over it, you have to use it. When properly placed, the rubber dam facilitates treatment by isolating the tooth from obstacles such as saliva and tongue that can disrupt any procedure. Proper rubber dam placement can be done quickly and will enhance the entire procedure. So no excuses. The rubber dam is used in endodontics because it ensures the following. Patient is protected from aspiration or from the swallowing of instruments, tooth debris, medicaments, and irrigation solutions. Clinician is protected from litigation, which means lawsuits. If you don't use a rubber dam, clinician is protected from litigation because of patient aspiration or swallowing of an endodontic file. Remember the case I presented? The dentist didn't use a rubber dam and the patient inhaled a file, went into his lung. Remember that case? Routine placement of the rubber dam is considered the standard of care. This is the legal term for using the rubber dam. Not only mandatory, okay, not only absolutely necessary, but also routine placement of the rubber dam is considered the standard of care. Using sodium hypochlorite is not considered the standard of care. But rubber dam placement is considered the standard of care. You see how important the rubber dam is? I mean, this book can't emphasize how important this rubber dam placement of the rubber dam is. I mean, mandatory, a must, standard of care, no excuses. A surgically clean operating field is isolated from saliva, hemorrhage, and other tissue fluids. The dam reduces the risk of cross-contamination of the root canal system, and it provides an excellent barrier to the potential spread of infectious agents. It is a required component of any infection control program. Required component. Soft tissues are retracted and protected. Visibility is improved. The rubber dam provides a dry field and reduces mirror fogging. Efficiency is increased. The rubber dam minimizes patient conversation during treatment and the need for frequent rinsing. It also relaxes the patient and saves time.